So in our talk about Monteggia fracture dislocation, we will start with an introduction. So Monteggia fracture dislocation is any fracture of the ulna associated with a radial head dislocation. So Monteggia is a combination of two injuries. It's a combination of a fracture of the ulna with a radial head dislocation. And Monteggia fracture dislocation occur more commonly in children and rarely in adults. And it is diagnosed by the forearm x-rays, the anterior-posterior and the lateral views, and it is treated either operatively or non-operatively. Moving on to talk about the mechanism of injury. So Monteggia fracture dislocation results from a fall on the outstretched hand with twisting force or a force that lead to hyperextension of the elbow joint. So same with the other upper limb injuries, Monteggia also occur from a fall on the outstretched hand, and it is associated with another force, so it's a fall and a twisting force or a fall and a hyperextension type of force. And it also can occur from a direct blow to the forearm and from high energy injuries. Now let's talk about the classification of the Monteggia fracture dislocation. So Monteggias are classified according to the Bado classification. Now Bado classifies Monteggias according to the direction of the radial head dislocation and the direction of the angulation of the ulna fracture into four types: type 1, type 2, type 3, and type 4. Now regarding the Bado type 1, so in type 1 we have an anterior dislocation of the radial head, and it is associated with angulated ulna fracture with the apex of the angulation pointing anteriorly. And this is the most common type, occur in 60% of Monteggia fractures. So on the left picture here, we can see a simplified drawing of the Bado type 1. So we can see that the radial head is dislocated because the radiocapitellar line does not cross the capitulum here, so the radial head is dislocated, and we can see that it is anteriorly dislocated, and we can also see that the ulna is fractured and angulated, and the apex of the angle is pointing anteriorly too. Now on the right picture here, we can see a lateral x-rays of the forearm, and it also shows that the radial head is dislocated anteriorly. We can see that the radiocapitellar line here does not cross the capitulum, meaning the radial head is dislocated and it is dislocated anteriorly. And we can see the ulna is also fractured and angulated, and the apex of the angulation is pointing anteriorly too. So this is a Bado type 1. Now regarding the Bado type 2, so in Bado type 2 we have a posterior dislocation of the radial head, and it is associated with angulated ulna fracture with the apex of the angulation pointing posteriorly. And this is the type of the worst prognosis. So on the left picture here, we have a simplified drawing showing the Bado type 2, and we can see that the radial head is dislocated posteriorly, and we can also see that the ulna is fractured with the angle of the fracture pointing posteriorly as well. And on the right picture here, we can see a lateral forearm x-rays, and it shows that the radial head here is dislocated posteriorly, and we can also see that the ulna, so this is here the ulna, is fractured right here, and the angle of the fracture is pointing posteriorly as well. So this is a Bado type 2. Now regarding the Bado type 3, so in type 3 we have a lateral dislocation of the radial head, and it is associated with ulnar fracture. So here we have a simplified drawing of an anterior-posterior view of the elbow, and we can see that we have a lateral dislocation of the radial head. We can see that the radiocapitellar line does not cross the capitulum here, so this is a lateral dislocation of the elbow, and we can also see that we have an ulnar fracture. And on the x-rays here on the right, we can see that we have a radial head dislocation. So this is here is the radial head. It is dislocated laterally, and we can see that we have a fracture of the ulna here, and it is angulated to the lateral side too. So this is a Bado type 3. Now regarding the Bado type 4. So in Bado type 4, we have a dislocation of the radial head in any direction with a fracture of both the radius and ulna. And here we have a simplified drawing showing that. So we have a fracture of both the radius and ulna, and we have a dislocation of the radial head, and this is a Bado type 4. Now moving on to talk about the clinical features. So the patient with a Monteggia fracture present with pain in the forearm and the elbow. And when doing a physical examination, we follow the same pattern of look, feel, move. So on looking, we look for swelling. The elbow is usually swollen, and we may also see a deformity of the ulna, which is usually obvious, but the elbow deformity is masked by swelling in most cases. You also inspect the lacerations for any evidence of open fractures. Now on feeling, you feel for tenderness, especially on the lateral side of the forearm in case of the Monteggia fractures, and you also do a neurovascular examination to look for nerve and vessel damage, and usually the radial nerve is damaged in these injuries. And on moving, you ask the patient to move their limb, but they refuse because of pain. And the examination is repeated multiple times to exclude compartment syndrome. Now let's talk about the imaging in Monteggia fracture dislocations. So the plain radiographs, the anterior-posterior, and the lateral x-rays of the forearm are usually enough for diagnosis, and the radiograph should include the elbow and the wrist joint to detect any injuries to the proximal or the distal radio-ulnar joints and the other joints. And the radial head is dislocated and does not point to the capitulum anymore, because normally the radius points to the capitulum in all elbow x-rays, and in Monteggia fractures it is dislocated, so it does not point to the capitulum anymore. And here we have an x-ray radiograph showing a lateral view of the forearm, and we can see that we have an ulnar fracture. It's very obvious. The apex of the angle is pointing anteriorly, and we also have a radial head dislocation. So if we draw the radiocapitellar line, we can see that the line does not cross the capitulum, so the line normally should be like that. But in case of the radial head dislocation, it does not cross the capitulum, meaning the elbow is dislocated, and in this case it is dislocated anteriorly. Now the ulnar fractures might be incomplete. They are also called green stick fractures. There is usually only bowing of the bone, and that is occur in children, and the radial head is not completely ossified. So in children, the ulnar fracture is not obvious because it is incomplete. Usually the ulna is only bowed a little bit, and the radial head is not fully ossified, so it's also not very obvious. So this injury can be easily missed in children. Now let's talk about the associated injuries. So the radiocapitellar joint is injured in all Monteggia fractures, and the proximal radio-ulnar joint is injured in all Monteggia fractures too, except in trans transolecranon fracture dislocations. So in transolecranon fracture dislocation, the olecranon is fractured, the radial head is dislocated, and the proximal radio-ulnar joint is normal. It is not injured. While in the other cases of the Monteggia fractures, the proximal radio-ulnar joint is injured. Now, other associated injuries with Monteggias include the radial head fracture. The radial head may be fractured in some cases, and the coronoid process may be also fractured in some cases. Now let's talk about the treatment in Monteggia fracture dislocations. So we have a non-operative and an operative treatment. So regarding the non-operative treatment, non-operative treatment is done in children for the incomplete fractures only, so for the green stick fractures only. Those fractures are reduced by restoring the ulna to its normal length by traction. And when the ulna is restored to its normal length, the radial head would relocate on its own. Then the forearm is immobilized in above elbow cast for 3 weeks, and re-examination is done to make sure that there is no nerve or vessel injury occurred during the reduction maneuver, and radiographs are repeated to make sure the reduction is perfect. And exercises are started as soon as possible to prevent stiffness. Now let's talk about the operative treatment. So the operative treatment is done when the ulnar fracture is a complete fracture in adults and in children. And the operative treatment is achieved with a closed reduction of the radial head and an open reduction internal fixation and deplating of the ulnar fracture. So the radial head is reduced by closed reduction. If it remains stable throughout the full range of motion of the elbow, then no further management is needed. But if the radius redislocates or it can't be reduced, then it has to be explored and repaired. Finally, let's talk about the complications of the Monteggia fracture dislocations. So we have an early and a late complications. Early complications include nerve injury, and those are mostly iatrogenic that happen during reduction or during surgery, and they are mostly neuropraxias that will recover on their own during a 2-month period of time. We also have vascular injuries, and those include injuries to the brachial artery, to the radial artery, and to the ulnar artery. And we also have compartment syndrome. Compartment syndrome occurs when there is increase in the pressure in the muscle compartments that would lead to impairing the blood reaching those compartments, and it would end up of necrosis of those muscle compartments. And compartment syndrome is caused by the injury to the muscles and to the soft tissues that happen during the injury, and it is diagnosed clinically by neurovascular examination, so it is repeated multiple times to make sure the compartment syndrome does not occur. Late complications, on the other hand, those include the malunion, and the malunion occur when the ulna is not perfectly reduced, which lead to the radial head remains dislocated, and this would end up in limiting the elbow flexion. Late complications also include non-union, and this is treated by plating and bone grafting. And we also have elbow stiffness. Elbow stiffness occurs especially when the radial head dislocation is missed and when the elbow is immobilized for a long period of time. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like and comment your ideas and questions. And this video is a part of a bigger class. It is called the Elbow and Forearm Trauma Masterclass. You can check it out. Link will be in the description of this video.